Are we hungry? Are we hungry? No? Sure? Thank you, because I am going to talk on two consecutive topics. And these two topics are very important. The first one is very important, very, very important. So I need you all to pay attention to the first topic. Second topic is relatively less important, but still it is must. So this is my profile. I have been trained in diabetic foot management from Amrita Institute, Kochi. I'm practicing as a diabetologist and a diabetic foot care expert from Aurangabad. First of all, we will go, how does a diabetic foot wound really occur? Anybody has got any idea how does it occur? Any comments on this? Sorry? Unknowingly. Why? Because of neuropathy. Okay. Anything else? Minor traumas are there, fine, fair enough. Lack of knowledge, okay. Callus formation. Anything else? Why the callus is there? Pressure pointation, that's the key. Thank you. So, we'll continue the mechanism of injury in a diabetic foot. It's because of pressure. Pressure is equal to force divided by the surface area. Force would be a perpendicular force of your body and a tangent force when you walk. If the shoes is ill-fitted or it is loosely fitted, then there is a shear force, the shoe force and the walking force, they have a brushing effect, and then the injuries occurs. If there is a small surface area, that area has got the highest pressure point, just like the first metatarsal head. In biomechanical aspect of ulcer formation, the breakdown skin, or once you walk, there is around 500 to 700 kilopascals pressure which has been there at the foot and your plantar surface, and this is the major cause of callosities formation, deformities, and non-healing. This is what the example which I was talking about. Yeah, this is a callosity, and if we deroof the callosity, or if we slightly slice it off, there is beneath an ulcer. A callosity itself will increase the pressure by 30 times. 30. You have to into it in 30. Whatever the pressure is, into 30, that amount of pressure is being exerted if there is a callosity there. So we have to manage the callosity first and foremost once you see it. If we say that the peak plantar pressure is 600 kilopascals, then there is ischemia and anoxia. In non-diabetic patient, there is an instant recovery, where in diabetic patient, there is a delayed recovery, which leads to formation of inflammation, erythema, warmth, leading to a blister formation, and then an ulcer. We have got a vascular phenomena also, in which if a 600 kilopascal pressure has been exerted while walking, the radial artery get occluded at 120 mm of mercury, that is only 15 kilopascals. Capillaries get occluded at 6 kilopascals, and we are exerting a pressure of 600 kilopascals while walking. It is 100 times more. That's why there is ischemia, and the recovery in a diabetic patient is has got a delayed recovery, and the chances of infection gets more in diabetic patient. This is what a diabetic foot, we have got a high arch here. First metatarsal head, we have got a plantar, he has a high arch. There's an intrinsic muscles strengthening or weakness, tightening. That is a pressure areas in this. Do you think that diabetic wounds or foot infections are from outside in? It is said that 85% of diabetic foot ulcers are within out. It's because of the pressure. 85% are because of pressure. 15% remaining, your trauma or something happens from outside, then that is there. But 85% are from within out. Repeated moderate force of routine unprotected walking can damage the feet in diabetic patients. Diabetic foot ulcer is a mechanical problem, and no amount of antibiotic or dressings will heal the ulcer unless and until the pressure is reduced. There is a graphical representation for or a pseudo scan, which we call as. The assessment of pseudo scan comes in this way. There is a graphical presentation along of the graphs. There is a digital presentation, or the markings are there. There is another type of a presentation where you can see your hotspots. Red spots are hotspots. These are the peak plantar pressures. These are the normal. This is normal. Here we got slightly increased pressures, whereas here a peak plantar pressures exerts. In a normal feet, everything is normal. In a flat feet, mid, first, second, third, fourth, fifth ray, in a high arch. If the structural abnormality starts increasing in a foot, the pressure distribution goes on decreasing, goes into various domains, and it increases in pressure points. The prevention of excess pressure on a point that tends to ulcerate is referred to as offloading. Most important step in preventing progression in a diabetic patient is to reduce the number of loading cycle, that is reduce walking, and redistributing the pressure by offloading. Offloading, it could be with the help of a footwear or surgical offloading. These are the methods of offloading. Basically, bed rest, crunches, total contact cast, modified footwears, rocker insole, molded insoles, lot of things are there. In foot orthosis, we have majorly two shoes modification. One is internal and one is external. These are number of numerous insoles. We have got a back offloader, front offloader, we have got a middle arch, we have got a front offloader, a ring, got toe separators, metatarsal bar. These are different upon the type of ulcer, upon type of pressures where it is exerting. Depending upon that, the pressure, the insole is being used and pressure is being distributed. These are the off soles. That is outer. This is a front offloader. This is a back offloader. This is a rocker bottom. This is a insole where we got a packets. Wherever the ulcer is there, we can remove that amount of packets from there and we can offload it. It's a simple process. This kind of a shoe or a sandal is available in which you can place this insole, and we can have a offloading at this typical ulcer area. This is a midfoot offloader. These are the customized insole depending upon the structure which we generate, the report which we generate from the pseudo scan. Then this kind of insole has been modified and it has been fitted in the shoe. These are customized insoles. These are farmer shoes. These are executive shoes. This is a cast where we get a negative, from which we get a negative cast like this, and this is a machine where we go and have a insole modification depending upon the cast. These are the offloaders. This is a MCR insole in which, depending upon the type of ulcer, we can offload it. There are numerous kind of ulcers, middle, first and fifth. Depending upon the type of ulcers, we can modify the insoles as per need. This is a elastic insole which has been fitted with the elastic bandages. If in case somebody says that I'm not able to use a footwear or a sandal in house, then this kind of a offloader is being given. This is a filler pad which is used in a high arch. This is a filler pad with an anterior rocker where we have got the anterior callosities or ulcer. Then this rocker is being used so that to offload the remaining portion. This is another type where we can have a heel offloading. This is a tarsal girdle. This is an elephant shape for a heel ulcer in a flat foot patient typically. Then if we say that in a high risk patient or a high risk foot, there is a loss of protective sensation, intrinsic muscles go into paralysis, there is a fixed gross deformities with a severe scarring, usually in a high risk foot patient. What we do is we mold the insole as per the patient's feet itself. And then what the results comes is in this way. If we see, here are the flat fits with a peak plantar pressures here, and once we mold the insole, then the pressure is being evenly distributed throughout the feet. So this is what we have to do in a diabetic foot patient. In a normal walking gait, the first metatarsal stance on a diabetic patient has got a highest contact point, and this leads to major ulcer formation at the first metatarsal head. This is a rocker. If we see, there is a beautifully curved insole as per the feet, and if you see, there is a huge difference. So the pressure gets reduced, and the chances of callosity formation or ulcer formation reduces by 60 to 70%. These are MCR insole chappals, normal for normal feet. These are modified insoles, which we have discussed already. This is a molded shoe with an insole for this patient. There is an ankle braces for a charcot foot abnormality, or a short foot, or the bony destruction is there and we have to offload it, then the braces are being used. This is a high patellar brace. This is the patellar braces. Again the same. Let's go to the cases. Couple of cases. 60 years old male, diabetic 20 years, mixed at 30 to 70, 30-70. Sugars fairly controlled, callosity in 6 months. On examination, callosity was there on second metatarsal head, 5 by 5 centimeter in diameter, mild neuropathy, ABI is normal. What to do? Any guesses? How to manage this patient if it comes down to your OPD? Remove the callus. Till what extent? That's a surgeon's call. Okay, fair enough. What is been practiced at your end? No, I'm just saying, what if in case this kind of a patient comes, what your surgeon would be doing it? Right from the core? Right from the core? Okay. Okay. Okay, yeah.
And recommending offloading of the 4 foot at least till the moving.
Okay. Okay. Anybody has got a different opinion from the man? Sorry? Okay, fair enough. Anything else?
4 foot offloads.
4 foot metatarsal bar, same thing. Anything else? What about the callus management? The callus management, how is it going to be? The same way the madam said?
Moist wound.
Moist wound. Moist dressing. Okay. Anything else? Leave it alone. Okay. I already told you, if the callosity is there, it is going to increase the pressure by 30 times. You really want to leave it alone?
To
I don't
scrape
think
it
so.
from the surface.
Sorry?
Scrape it from the surface.
Yes, scrape it from the surface. Thank you. It has to be scraped from the surface. We are not supposed to create a wound, neither even a single blood drop in a diabetic patient. If we create a wound, if it doesn't heal, then you had it. This is what I did. Just see the images. The size was this way. It has been removed in this. This is a Mandakini offloading technique which has been used. It is very simple. You can get it in your, you can do it routinely in your own clinical practice. This is what the footwear modification which I did, or the first metatarsal bar here and a scoop here, so to accommodate the callosity. Video please. From the beginning, please. Just play it, please. It's not getting played? Fine. Just get back to the slides, please. What is done is, we roll your gloves. Yeah, it's available on YouTube also. You can just Google it up and you can see the Mandakini offloading technique in the. Yeah, Dr. Sunil Kari has been designed that it is called as Mandakini offloading. It is called as Samadhan offloading. There are different names on that. That is what it is done is that we roll the glove with air trapped in it. Then we try and with a what do you say it as, a bandage has been placed, or a dynaplast is it has been trapped in a dynaplast, and then a bar is created. Then we place beneath the wherever we want to offload it, and then we stick it around. Slides. Started from the beginning, the slides, so that I can just go it off. There is a second case. There is a callosity here. A 70 years male, diabetic, gut controlled, neuropathic, has shown to a plastic surgeon, shown to general surgeon, debrided, underwent skin grafting 3 times, and had a punch biopsy for the same. Any clues what exactly the pathology would be? Surrounding callus is they fine? Anything, what can, some foreign body can be sitting inside, okay? Anything else? Pressures, thank you. It is just because of the pressure. This is the, this thing. What kind of management are we going to do for this patient? Offloading. What for the callosity? Again remove it. The first day, third, 42nd day, ulcer healed completely by its own. This was the footwear modification which I did. There was a, I have a MCR insole with in my OPD. As per my need, I modify the insole as per needed. This is a first metatarsal joint ulcers, and there is a tip ulcer. What kind of management and what kind of a cause would be for this patient? Any kind of clue? What abnormality could be there for this and this? Any structural abnormality? I am seeing about, sorry? Ulcer crater. Okay. No. There are no hamarto, there is no clauto. Hamarto is in different form. It has to be in this way, straight. Or claw has to be in this way. It is not there in the pictures. Not, it couldn't be a single toe which is going to go into hammer or claw. There has to be accompanying 2 or 3 toes along with it. So what kind of abnormality it would be? Fine. There is a first metatarsal MTP joint stiffness in this patients. So how to manage this? Any clue? Fine. What we did is, there is a first metatarsal fascia. The plantar fascia has been tightened up, because of which the joint is stiff, and because of which the pressure and the ulcer is formed. What we did is, we cut across the selected fascia, that is called as fasciotomy here, and see the range of movement. It got increased. This is how you can offload it surgically. This is Killer's procedure of offloading. First metatarsal, we go with a bone osteotomy here, and then the ulcer get heals. This is normal bone. This is post-operative. The excision has been there. Done. The first metatarsal. There is flexor tenotomy, which we did for this patient. The ulcer healed up completely. This is a claw toe correction with glidotelar tendon transfers, which has been done with a Z plasty here to correct the claw toe. We insert a pin here straight across after correcting the tendon, and then we placed it for a week, for 15 to 20 days, and then we remove the plaster and the pin. Then the toes get corrected. See the correction. This has been a plantar forefoot ulcers associated with contracture. Basically, if we see, this is a high pressure area in a diabetic patient. Normally, this is not there first. So what we do is, we lengthen the gastrocnemius. We go with a transection of a gastrocnemius soleus tendon, and the forefoot pressure is being relieved. This is surgical correction. You can see this spidograph, huge amount of pressure here. As compared to that, post-operative, the pressure is less. Same with the graphical representation. This is forefoot ulcer. We excise the second metatarsal head in order to correct the pressure point here. The ulcer healed. This is surgical offloading techniques. Not only the insole or outsole has been modified, surgically also we offload the things. If we fail to go with the conventional offloading techniques, and if the bony prominence is severe on x-rays or on inspection, then we adopt for a surgical correction. Another same way, first metatarsal head transfer. These are AFOs. These are plastic molded outsoles where we can put a plaster. In spite of plaster, we can go with this. These are lighter. These are more convenient, patient friendly. Patient can walk more steady as compared to plasters. This type of insole or a foot correction is used. It's customized design. There are silicone insoles also, which are commercially available, but their results are not that promising as compared to MCR insoles or conventional outer sole modification. There is a term called as total contact cast. Anybody has heard about it? What exactly it is, and for what condition is being used? Any clue? Heel ulcer. Okay. Anybody has got any other opinion? Okay. Okay. Fair enough. Any other entity? Have you heard about Charcot foot? Yes. In Charcot foot, we apply total contact cast to prevent the whole foot to be in a single entity. Then the destruction get lessen up, the recovery gets fasten up, and the destruction halts at its same point, and the bones try to get fused by its own. This is the total contact cast. This is a male patient. Here also here, it healed up completely. The bony destruction has been there. This is a total contact cast with a bony window. When it's been done where there is a ulcer and we need to dress it regularly, so we create a bony window in it to dress the ulcer, and rest of the feet is been offloaded with a total contact cast. This is what foam is being used, where the foot imprint is being implicated, and this is how what the footwear inner sole is being modified for this patient, for the same patient. What we do is, we pour a plaster of Paris in it, we let it set. Once it's dry up, a negative cast has been created. Then we go on to create a positive cast, and then the positive cast is placed here with the insole on that top, and then heated, and then the insole has been modified, molded. There is another term where we lengthen tendo Achilles, because if we have a 4-foot amputation, then there is peak plantar pressure occurring at the front point, because the gates and the routine structure disturbs. For preventing those, we lengthen a TA, we do a TA lengthening procedure. Tendo Achilles lengthening is been done to offload the foot. It can be done for the 4-foot offloading also. As we have I have shown you the gastrocnemius tendon lengthening, same thing can be done in tendo Achilles also. Deformed foot with a good footwear is preferable to amputated leg with sophisticated prosthesis. This is what I mean to say. Foot are deformed, no doubt, but still the patient or the person can walk on his or her feet with a modified footwear that is more preferable than an amputated leg. Why? Why? Any clues? Because there is 30 times the pressure or the cardiac output or the cardiac load is increased after amputation, and the patient goes into cardiac arrest or a heart failure or MI within 5 years' time. So it is preferable to have a deformed fit with a good footwear modification. The same way, in a patient with diabetic peripheral neuropathy, distance needs to be measured in minutes and not in kilometers. The ultimate goal is to prevention of amputation, protecting the feet for further complication. Periodic offloading and care is needed. Do not allow your patient to leave clinic with wearing the same pair of shoes which has caused him an ulcer. Early detection and protection of high pressure areas in a foot and corrective footwear orthosis is the only strategy to prevent loss in a diabetic foot. If offloading is not done to the patient walks to its own death. I would like to end my lecture with a Sanskrit slogan, Charita Charta Bhagya, states that the person who walks his fortune walks ahead to him. Thank you.